Hola a todos, buenas tardes. Vamos a tratar de iniciar puntual. Eh, Ahora está con nosotros la doctora CARRIE SCHINSTOCK. Ella se encuentra en la Mayo Clinic. Eh, Ella es ahora la directora de la división de trasplante renal y ella se formó tanto en la parte de medicina interna como nefrología en la clínica Mayo. Sí, ella es una experta en todo lo que tiene que ver con anticuerpos. El paciente tiene mucho como antecedente de haber trabajado en investigación translacional y bueno, pues nos va a dar ahora el tema de trasplante renal en pacientes altamente sensibilizados. Doctora Carrie, you can start.
Thank you very much. This is I feel privileged to have this invitation. So today, as he mentioned, I'm going to talk about kidney transplantation in highly sensitized patients. So we're going to start with the case. We had a 42-year-old male with a history of IgA nephropathy. He had a prior kidney transplant back in 2012 that unfortunately failed in 2015 in the context of rejection and non-compliance. He started back on hemodialysis in 2015 and has been on the transplant waiting list since that time. He does have an approved living donor, but unfortunately this donor is incompatible. There is a positive flow cytometric cross-match with a B flow or B channel shift of 180, the negative being 160, so clearly positive. And his calculated panel reactive antibody is 99.8%. And that brings me to the goals and objectives of my talk today. First, I'm going to spend some time doing the background. I want to talk about the various techniques that are used to detect and to measure anti-HLA antibodies and talk about their limitations. Two, I'm going to talk about the risk of antibody-mediated rejection with incompatible transplantation. We'll then develop an approach for when to decide when to go through HLA incompatible transplant. And lastly, I'm going to talk about a couple new therapies for desensitization and also antibody-mediated rejection that are on the horizon. So with that, what about the tools for measuring HLA antibody? So first, the most basic of the tools, more of a historical tool for measuring or detecting HLA antibody is the complement-dependent cytotoxicity cross-match. There are also flow cytometric cross-match assays that are more sensitive and have some semi-quantitative in nature. And then lastly, you have your solid phase anti-HLA testing. These are your single antigen beads. So as a reminder, this illustration is to really show how these assays work. In all of the assays, you have the recipient serum, and this recipient serum includes the anti-HLA antibodies. When we're thinking about cross matches, that serum is added to donor lymphocytes. It's then added to complement. And if there is a positive reaction, you have a positive CDC cross match. That's a yes or no answer. There's no quantification with this CDC cross match. Now, with the flow cytometric cross match, this is what's typically used at our center when we're doing cross matches. Again, we put the serum on donor lymphocytes. There is a fluorescent conjugated anti-human globulin that is added to that mixture. It is washed, and then the antibodies bound to the lymphocytes and the fluorescent conjugated anti-human globulin are then added to a flow cytometer. And if you get some fluorescence, you have a positive flow cytometric cross-match. And lastly, you have your solid phase assays. Again, you have the recipient serum that includes the HLA antibodies. This serum is actually added to a plate that has beads. Each of these beads has a different HLA antigen on it, okay? You then add the fluorescent conjugated anti-human globulin, and similar to the flow cytometric cross-match, you go through a flow cytometer. With this, though, you get mean fluorescence intensity of various different colors. Each of the different colors indicates a different antibody. So that's your single antigen bead result. So putting that all together, you have your CDC or complement-dependent cytotoxicity cross-match. This is your least sensitive, actually. It only gives you this positive or negative result. Then you have your flow cytometric cross-match assays, or flow cross-match. This has intermediate sensitivity. So it is more sensitive than your CDC cross-match. The other advantage of using the flow cytometric cross-match is that it's semi-quantitative. You get a measurement called the mean channel shift, which gives you some idea of the positivity or the amount of antibody in that sample. And lastly, you have your solid phase assays. These are also Luminex. They are the most sensitive of all the tests that are available. What's special about this test is that you're not only able to sensitively detect your antibody, but you can determine the HLA antibody specificity, which is really helpful. And it is also semi-quantitative, so it gives you some amount of antibody as measured as MFI. Now, the single antigen bead test, in my opinion, is our best test that is available. Now in the United States, actually, for many non-sensitized patients, we only use the donor-specific, or we only use the single antigen bead test. And there are even what's called virtual cross-matches, as I'll talk about later. Now, with the mean fluorescence intensity, it's important to recognize that it is truly semi-quantitative. So if you have an MFI that goes from 1,000 to 2,000, for example, that may not be a real change in antibody because of the semi-quantitative nature. Also, each center defines what their positivity is. As you see here, there's a MFI value that is their true negative, and then there's the true positive value, but in between there's this gray zone, and that gray zone is an MFI that's about 1,000. So when you get the results, just because there is a positive result, and even if that MFI is 1,000, you still need to be thinking about, is this a true antibody? And that's where working closely with your tissue typing group, getting a good history about sensitization from the patient is helpful in determining, is this an antibody or is this not an antibody? I'm sorry. In most centers, the MFI cutoff is 1,000 to 1,500. Now, there's some other limitations to the MFI or the semi-quantitative nature of the single antigen bead. First, there can be many laboratory issues. There can be prozone, bead interference, and even a phenomenon that's called shared epitope phenomenon. There's also non-uniform laboratory procedures and reporting. So just because one center has an MFI of 1,000 doesn't mean if you tested that same sample at another center, you're going to get the same result. I think that's changing, however. And then I mentioned some of these other limitations. The first is this concept of bead saturation. So some patients, especially the highly sensitized patients, who have CPRAs greater than 90%, there can be so much alloantibody or so much HLA antibody that it doesn't bind to the beads correctly. as I said, there's these spheres with HLA antibodies, or HLA antigens rather. And if you have so many antibodies that bind up all of those antigens, it becomes saturated. All of the binding sites are occupied and you have some maximal signal. There's also the phenomenon of this hook effect or prozone. And what happens here is that, again, there is some problem with the amount of antibody in the binding. And so at some point, what happens is there's so much antibody that it doesn't bind the beads correctly. And instead of the MFI going up, the antibody actually goes down. And you can only detect that when you dilute the serum and repeat the testing. So how do you overcome these various limitations? One of the ways, if you suspect that there may be some problems with bead saturation or a prozone effect, then I would dilute the serum and recheck that serum. And if you find that the result actually increases, you can be concerned that there's one of these phenomena. This only typically happens in your highly, highly sensitized patients, though. This is another example of what happens with the MFI at various dilutions. So, as you can see here, or for this, I should go back. For this particular study, we had 20 different patients with specificities to multiple antibodies. Each of these 20 patients had a 100% CPRA. And we looked at the various MFIs of the various antigens. And then we also looked at those MFI values at different titers of that antibody. And what you can see here is that when the antibody level is fairly low, or a low MFI, low antibody titer, the MFI is fairly quantitative in a linear fashion. But when you have so much antibody in these highly sensitized patients, when it saturates the bead, even with a higher titer antibody, as shown on the x-axis here, the MFI is essentially the same. So the MFI maxes out at this 25 to 35,000 range. So what about a virtual crossmatch? I'm not sure this is used in Mexico very often. It's beginning to be used more often in the United States. And this is where we're actually using these solid phase assays to predict what that crossmatch is going to be. So an example would be you have a completely negative solid phase assay. So you're going to predict that you're going to have a negative flow crossmatch or negative CDC crossmatch. And we're using this more often because then we do not need to get repeated serum from patients, especially in the context of kidney pair donation or other scenarios. Now, what's important to recognize is that the virtual crossmatch is excellent for the non-sensitized patient or the patient without any antibodies, but it can be unreliable if you have very highly sensitized patients who are in that 90 to 100% CPRA range. And that's purely because there's limitations with the single antigen beads. So what about quantifying sensitization? So, at least in the United States, we quantify sensitization or determine the breadth of sensitization for a particular individual by using the calculated panel reactive antibody, or CPRA. What this is it's an estimate of the proportion of deceased donors to which the candidate has HLA antibodies. And the score is expressed as a percent between 0% and 100%. And it's really helpful to determine how easily a candidate can find a compatible donor. And I'll say in the current era in the United States with our new allocation system and robust kidney pair donation programs, I have a pretty good idea whether someone is going to be able to find a donor based on their CPRA. Again, in the United States, we use this online calculator to determine this CPRA, but like with everything else, there are some caveats. First, when we do the CPRA calculation, we consider an antigen unacceptable based on the MFI of that particular antibody. At Mayo Clinic in Rochester, our cutoff for positivity is 2,000, okay? But at other centers, their cutoff may be 500 or 1,000. So the CPRA may differ at different centers just based on how that center interprets the CPRA. Also, the DP or DQ alpha antibodies are not included in this calculator. A key point that I continually remind my fellows and trainees is that just because a patient has a low CPRA doesn't mean they're immunologically naive. It doesn't mean that they're never going to have a rejection. The CPRA is very useful for allocation. It's very helpful if we are trying to determine whether a patient is going to find a donor. But patients are still able to develop antibody-mediated rejection when all single antigen B testing is negative or the CPRA is negative, because this test does not tell us anything about the memory B cell response. It also doesn't tell us anything about whether a patient is going to develop de novo or new antibodies at a later time. It's also important to recognize that not all patients with a CPRA of 100% are the same. In the United States, we're starting to use what's called the precise CPRA. This is particularly helpful in these patients with a CPRA of 100%, because we've really found that the rate of transplant differs among patients with a precise CPRA of 99.5% versus 99.9%. Again, this is really helpful for me to understand whether or not a patient can be transplanted. This is an illustration of that. As many of you probably know, in the United States in 2014, they overhauled our allocation system. And so now our allocation system gives tremendous priority to patients who have 100% CPRA. In fact, they get almost 200 years of extra waiting time on our list. So there is a lot of priority. But what we wanted to do was look at the transplantation rate based on various CPRAs, okay? And we'll just look at the red line here. On the x-axis, you see the CPRA, and then the line is telling us the transplant rate. This black line is showing the average transplant rate. And you see the average transplant rate is fairly steady. It actually kind of increases among patients with a CPRA of 80%, all the way up to 99.8%, to be honest with you. And then when the patient gets up to a CPRA of 99.9%, you see the transplantation rate almost plummet. So these patients get lots of priority to transplant, but there's just not enough organs available. So let's go back to our case. Remember, we had this 42-year-old with IgA nephropathy who had a prior kidney transplant. He's highly sensitized and has been on the waiting list since 2015 and has an incompatible living donor transplant, or has an incompatible living donor. So what are the options? What should the patient do? So, at least the way that we're thinking about it in our current era is we're thinking about kidney pair donation. The patient can be on the deceased donor waiting list, or we just go forward with a living donor HLA incompatible transplant or positive cross-match transplant. So kidney pair donation, as a reminder to you all, in this case, in simple terms, there is a donor and recipient pair 1. They are incompatible. They may be different blood type, for example, and you have a donor recipient pair number 2. They are also incompatible. But then when you mix and use the donor 1 for recipient 2 and donor 2 for recipient 1, you're able to get both of those recipients transplanted. Now, this is the most simple of kidney pair donation, but as you can see here, there's a lot of different ways of going about this. Right now, most of the time, kidney pair donation involves chains. And in these chains, they start with a non-directed donor that sets off a chain of multiple transplants. Kidney pair donation is great, but like everything else, there are limitations. In our current kidney pair donation system, there are recipients with certain characteristics who may wait longer. And, frankly, certain patients with certain characteristics may never get a transplant, depending on the size of the pool, right? So patients with a really high CPRA or even blood group O are less likely to benefit in a kidney pair donation program, or at least have to wait much longer. This is data from the Mayo kidney pair donation program, and you can see that. So here on the y-axis, I'm showing the blood types. On the X, or on the top, I'm showing the CPRAs, okay? And this is the days that those patients are going to wait in kidney pair donation. You can see that patients with a blood type O have longer waiting times regardless of the CPRA. And you can also see that there's longer wait times for the highest sensitization patients. So the patients with the CPRA in our program had to wait much longer than those patients with lower CPRA. Now you can see this outlier. There was a patient with a blood group AB with a 90 to 97%, but the number of patients in that AB group was really small, so that was likely a skewed result. But in general, blood group O patients and sensitized patients are going to have to wait longer. After our initial experience in kidney pair donation, we actually combined kidney pair donation with desensitization or positive cross-match transplant. With this approach, we were able to increase the percentage of patients with a high CPRA getting transplanted. This is historical in some sense. This was back in 2009 to 2013, before our new allocation system. When we only use kidney pair donation, only 11% of our patients with a CPRA greater than 95% actually got transplanted, which was, pretty dismal when I'm thinking about it now. Then in January 2013, actually through 2015, when we paired KPD with desensitization, about 30% of our patients were able to get transplanted. So there's KPD, and then there's also waiting for the deceased donor kidney transplant. Know that in the United States, again, there's this new allocation system for highly sensitized candidates. There's other programs similar. There's an acceptable mismatch program in Europe, again, giving priority to the sensitized patients. In the highly sensitized patient program in Canada. In the United States, this is what we do for allocation based on sensitization. In the red, you see the way our previous allocation system worked. Any patient with a CPRA from 0 to 80% got 0 points, while all patients with a CPRA of 80 to 100 got 4 points. Okay, so we gave some additional points, but this just wasn't good enough. So in 2014, the points given was based on the sliding scale that started at 20% CPRA actually, but then started to go up precipitously after 90%. So that's what you see here in the green line. And now patients with a 98% CPRA get 25 extra points. If a patient has a 99 CPRA, they get 58 extra points. And then if a patient has 100% CPRA, they get 217 extra years of waning time or additional points on that waning list. So this new allocation system was great. you can see here how the percent of transplants, or the percent of transplants to CPRA patients of 99 to 100% was extremely low up until the allocation system changed. Right after that change, there was a huge bump in sensitized patients getting transplanted, and then it's leveled off, and about 12% of the current transplants are in highly sensitized patients. So this has led to a decline in the number of highly sensitized patients on the waiting list in the United States. As of this time, there were about 7,000 patients on the waiting list with that CPRA. When you went down to 2016 and 17, there were only about 5,000. So there was this gradual decline. However, I do want to remind you that, like with kidney pair donation, there are these patients who are going to have a reduced rate of transplantation regardless. So now the sensitized patients who are left have a CPRA of 99.9%. So this brings me to HLA incompatible transplant or positive cross-match kidney transplantation. So you've tried your kidney pair donation. That may not be successful. You may have tried the deceased donor system. That's not successful in getting your patient transplanted. So at this point is when you're thinking, we need to change our strategy. Now, why are we even thinking about this? This is data from Bob Montgomery showing that there is actually an advantage to patient survival with incompatible kidney transplant. This was shown back in 2011 in a single center cohort. You see here at the top is the patient survival among patients who received some desensitization. This was higher than those similar patients who remained on dialysis or transplant. And then the patients who had the lowest patient survival remained on dialysis. This similar study was repeated in a multi-center cohort, and you see that there was a similar conclusion. Now, there is this survival benefit, or at least a patient survival benefit, with positive cross-match kidney transplantation, but this does come at some risk to the allograft. So there is a reduced 5-year allograft survival following positive cross-match kidney transplant. This is data from the Mayo Clinic, where we showed that the graft survival among patients who had a positive flow cross-match was about 70% at 5 years, compared to about 88% at 5 years among those patients who had a negative cross-match kidney transplant. So how do you decide when it is appropriate to try an incompatible transplant? Well, I think about determining the risk of the transplant based on the various tests that are available, okay? So if you recall, in the early part of this talk, I talked about single antigen B testing. We talked about CDC cross-match testing and flow cross-match testing. We use this again to help us determine the risk. Obviously, you have patients who are at the lowest risk. They have completely negative cross-matches, completely negative donor-specific antibody. These patients are the lowest risk. And then you have those patients at the highest risk that, at least in our hands, we're not even going to try a transplant if the CDC is positive or if they have a very high flow cross-match with known donor-specific antibody positivity. And then you have your patients who are kind of in the middle, in the yellow box. I'm showing patients who have a negative cross-match, but when you use very sensitive testing, they have positive DSA. And then again, you have patients who have positive DSA, but they have, a high flow cross-match. And so we really try to think about not only should we go to incompatible transplant, but at what point should we do the incompatible transplant, or how risky is the transplant? And indeed, we can use these tools. This is data, a multi-center study actually, that showed the percentage of graft loss based on the amount of antibody as determined by cross-matching. The highest proportion of graft loss actually is among those patients who have the complement-dependent cytotoxic cross-match positivity. Interesting, you'll note that most of the graft loss, I shouldn't say most of the graft loss, but the greatest jump in graft loss occurs very early. About 10% of these grafts are lost even before the first year of transplant. And then you have the next worst allograft losses and your flow cytometric cross-match positive patients. And then you have your single antigen bead positivity patients. And lastly, you have this graft loss among patients who undergo completely compatible transplant. We also know that there's increasing incidence of chronic antibody-mediated rejection based on the flow cross-match and single antigen bead assay. Again, this is data from the Mayo Clinic where we divided patients in the various categories depending on their single antigen bead and donor-specific antibody results in the cross-match. And you can see that as the B-flow cross-match increases, the percentage of patients who have chronic antibody-mediated rejection increases. You can also see here that in all cohorts, for the most part, the degree of chronic antibody-mediated rejection increases. So among patients who had known donor-specific antibody and a high B-flow cross-match, about 60% of them develop chronic antibody-mediated rejection at 5 years. So going back to this question, what do you think about when you're going to consider doing a positive cross-match kidney transplant? And, I'm going to have to think about a lot of things. So the first thing that I think about is the sensitization. At least with our resources, with a robust kidney pair donation program and our allocation, I really think about sensitization. So I'm only going to consider an incompatible transplant if someone has a CPRA that's greater than 99%, or I've tried kidney pair donation for a long time and it doesn't work. Now, our practice has changed. 10 years ago, my CPRA cutoff was much less. So at that point, anyone greater than 90% was difficult to transplant. So I may have been more likely to consider positive cross-match. You also have to consider the degree of DSA in cross-match positivity. As I showed you before, the higher the DSA, the higher the cross-match, or the higher the MFI, higher the mean channel shift, the more likely that patient is going to have rejection, more likely they're going to experience graft loss. I also think about their time on dialysis. Recall, dialysis is not good for patients. Long-term dialysis is associated with reduced patient survival. So I'm going to consider incompatible transplant more readily among patients who've been on dialysis a long time. It's going to depend on your access to kidney pair donation. If this isn't even available at your center, you may be more likely to do incompatible transplant. And you also have to think about what resources does your center have. So, there's one thing about doing incompatible transplant, but there is another. How are you going to treat the rejection if it occurs? If you do not have access to a timely biopsy or access to plasmapheresis or an expert tissue typing lab, and some of the therapies that are necessary to treat to treat rejection, then it may not be a good idea to try incompatible transplant. And then you also have to think about your own expertise. How comfortable are you in evaluating the antibodies? How comfortable are you at recognizing rejection, for example? So this is our approach, to a patient like discussed earlier, who has an incompatible live donor. So they're all going to go on a deceased donor waiting list. And, at least with what we have available, all of the patients are going to try some kidney pair donation program. If they have a CPRA less than 90%, they're really going to stay in kidney pair donation. We're not going to consider incompatible transplant at all. However, if their CPRA is greater than 90%, and more currently even greater than 99%, and if the flow cross match is if the flow cross match is positive, but the CDC is negative, then we might consider a kidney transplant at that point. So lastly, I'm going to talk about a few of the new options that are available. There's several new options that are available, or at least drugs that are in clinical trials. There are complement inhibitors, IL-6 inhibitors like clazakizumab. There's IgG endopeptidase. There are now anti-CD38 inhibitors, anti-CD20 inhibitors, and proteasome inhibitors. For the sake of time, we're not going to discuss all of these, but we will talk a little bit about the complement inhibitors and also IgG endopeptidase. Again, I recognize that these may not be available, and they're not even all available to me, but I think it's exciting to see what's on the horizon. So what about complement inhibitors? So we used, we did a clinical trial over 10 years ago where we had patients who had a positive cross-match. They had a negative CDC cross-match, but positive B-flow cross-match, and treated them with plasmapheresis and IVIG to get their B-flow cross-match less than 300 on the day of transplant. We had 26 patients in the initial cohort and 30 patients who were followed up long-term. And what we did was gave them eculizumab at the day of transplant, and then we continued this on a monthly basis until their B-flow cross-match started to go down and was at least less than 200. In fact, in this particular study, interestingly, 9 patients received eculizumab for the entire year. And we had quite remarkable results. We found that eculizumab was associated with a reduced proportion of early active antibody-mediated rejection. So when we looked at a historical cohort, we found that with these characteristics, about 40% of them had an early acute antibody-mediated rejection. However, in the eculizumab cohort, only 7.7% had an early acute rejection. Early meaning, or early defined as a rejection less than 30 days post-transplant. Because of these results, a multi-center study was later done. Unfortunately, like many studies in this space, there were problems. This study was very difficult to enroll. By the time this study was ongoing, there was differences in the culture. Kidney pair donation programs were becoming more successful and more popular. And so it was difficult to enroll. And so ultimately there were lower risk patients included in this particular study, or at least lower risk patients than were in our initial single center study. But despite this, in the post hoc analysis, they found that there was reduced antibody of all grades among patients who were treated with eculizumab, 11% versus 29%. And again, among the highest risk patients, the rate of rejection was 16.7% versus 53.8%. Now, these were exciting results. But unfortunately, when we followed these patients long-term, we found that both control patients and the eculizumab patients did go on to develop chronic antibody-mediated rejection. So although it appears to be very helpful in treating or avoiding that early graft dysfunction and early rejection, many of them go on to develop chronic active antibody-mediated rejection. In fact, when we looked at 7 and 10 years, there was no difference in allograft survival among the various groups. Only the negative cross-match group had improved allograft survival. So, generally we do not use eculizumab now for our incompatible transplants. However, we do use eculizumab for treating early antibody-mediated rejection, because we found it to be quite useful. This is a single center study from our center again, where we had a cohort of patients who had early antibody-mediated rejection, early being within the first month, and when their GFR was the lowest at the time of diagnosis, that's when we gave them the eculizumab. But you can see that within 7 days, you are already seeing an improvement in their allograft function, and this extends on. And at last follow-up, their kidney function appears even to be better than it was at baseline. So summary for eculizumab, I think that there may be a potential role to prevent early ABMR in patients who have a very high cross-match going into transplant. It's likely effective at treating early ABMR. We do at our center. We're fortunate to have it available, but, it does not appear to lead to improved allograft survival. So what about IgG endopeptidase? This is another exciting agent. This is IDAS or milfidase. This is a recombinant cysteine protease. And it's remarkable because it completely cleaves your IgG into your Fab and your FCC fragments. So they don't work anymore. Stan Jordan and his group used this in a desensitization study among patients from the United States and also patients from Sweden. And this is what they found. There was a remarkable effect on circulating IgG. On this graph, you see what the IgG concentration in the serum was right before treatment. Within a half an hour of treatment, you see a dramatic reduction, and the antibody is completely gone at 4 hours. So it's very, very helpful. However, as you can see, at about 7 to 14 days, you're beginning to see a rebound of the antibody. But it's just remarkable that it completely cleaves the FC and the Fab fragments. Here are the outcomes from this study, or at least the early outcomes in this 2017 paper. They had 1 hyperacute rejection, and 10 patients did develop an antibody-mediated rejection from 2 to 5 weeks post-transplant. The main point is that this leads to a very rapid reduction in IgG, but there is a rebound. The other thing to remember is that over time, anti-IDAS antibodies can form, and so this therapy is not to be effective, or is unlikely to be effective with repeated use. And it's really best if this is used as a combination therapy. So in summary, single antigen B testing to detect donor-specific antibody is great, but it does have limitations. And it's really important that these limitations be addressed to appropriately interpret the results. Ultimately, the decision to do desensitization or a positive cross-match transplant really depends on the size of your KPD or kidney pair donation pool and the allocation system that you're working with. So really, what are the center characteristics? And lastly, it's really an exciting time to study antibody and be in this field because there are several new therapies available, not only for desensitization, but to treat antibody-mediated rejection. So with that, I will close and open it up to questions.
Thank you so much, Dr. CARRIE, for this excellent presentation. We know that Mayo Clinic is one of the hospitals with more experience in highly sensitized patients around the world. And then for us, it's very important your input in this fascinating issue. Okay, I will talk in Spanish. Por favor, si tienen alguna pregunta, tenemos el chat donde lo pueden mostrar o a través del área de preguntas y respuestas. Doctora CARRIE, hoy en día, entonces, en el flujo de hacia dónde orientar el paciente, la primera opción debería ser los trasplantes pareados, ¿es correcto?
Yes, if that's available. I recognize that it's not necessarily available at all centers, but that would be what I advise the patient to do first.
Sí, es correcto. Habíamos platicado hace un momento de las características del sistema de salud en nuestro país, que hay múltiples instituciones, y cuando uno quiere ampliar el pool de pares, nos encontramos con la dificultad de el traslado de pacientes de diferentes ciudades o que pertenecen a diferentes instituciones, y eso limita el intercambio de donadores. Pero bueno, pues habrá que intentarlo. Varios países han logrado superar estos problemas y creo que debemos intentarlo, ¿no? Respecto a las terapias de desensibilización, cuando ustedes ingresan pacientes con flow positivo, CDC negativo y que deciden trasplantarlos previa desensibilización, ¿qué esquema utilizan para desensibilizar estos pacientes?
We would do plasmapheresis and IVIG first to make sure their cross-match or their B-flow cross-match is less than 300. That number is going to differ at each center, but it's definitely a negative CDC cross-match. And then we probably would give them eculizumab also at the time of transplant. I recognize that long-term it isn't associated with a major difference in the rates of chronic antibody-mediated rejection, and it, at least showed in our single-center study that it didn't lead to improved survival. But from my own patient experience, or not my own patient experience, but provider experience, the use of eculizumab has made it much easier for us to take care of patients. So we are using less plasmapheresis, their hospital stays are shorter, the patients are getting less sick, there are less wound infections, that kind of things. So that's how we would do it. But I'll be completely honest with you, in our current environment, and I hope that your system can get to this, that we rarely have to do those transplants. Since 2014, we just don't really do that because we have other systems.
Ya, es muy importante esta parte, ¿no? Como ustedes fueron un centro de referencia incluso para este tipo de trasplantes, de desensibilización, y bueno, ahora la tendencia es tratar de encontrar el mejor match con donadores pareados y mejora mucho el pronóstico, ¿no? Uno espera que el pronóstico cambie radicalmente con esto.
Yes.
Nos preguntan...
And I think that I would use our experience as somewhat of an inspiration, because it is possible. I was in a lot of discussions early on about kidney pair donation, for example, and there's a lot of disagreements. People don't want to, come together. There, a lot of reasons not to do it. But once, you start at one site and you just gradually expand it, over the years, you see that it works, and you can work this out.
Sí, correcto. Nos pregunta la doctora Mara si en pacientes pediátricos tienen algún cuidado especial, ya sea para trasplante pareado o desensibilización, cuando hacían esto más frecuentemente.
Yeah, good question. There's probably not much different in the pediatric population. I think the only thing is I would be much more hesitant to try the incompatible transplant for them for two reasons. One, I think it's most obvious that their long-term survival is much greater. And so, they're likely going to need repeated transplants. And so that positive cross-match transplant can be a real problem for transplant later on. So I would avoid it that way because they could become more sensitized later. The other thing is that the young patient often can do better on dialysis for longer, and so they may not have that same kind of survival benefit that, you know, some adults would, for example.
Ujú.
I don't think that's been, you know, clearly studied, but those are some of the thoughts that I have about it.
Okay. Hemos tenido un par de pacientes altamente sensibilizados, muy difícil de encontrar donador compatible y que curiosamente han tenido un hermano HLA idénticos, pero diferente grupo sanguíneo. Y hemos preferido ir con ABO incompatible, claro, con títulos de anticuerpos muy bajitos que han tenido pues éxito. ¿Con qué frecuencia encuentran este escenario? Es decir, ¿ustedes a todos les buscan una opción ABO incompatible?
Well, not always, but I think the approach that you brought up is a great one. If you're able to successfully do an ABO incompatible transplant with an HLA identical sibling, the graft survival is excellent. The challenge is that early time period, you know, because the ABO transplants, at least in our hands, they can be tricky. But I know it is done. And I think they have very good outcomes if you're able to get through that initial period. And if the titer is low, like you said, it's you know, you can often get through that initial period.
Pues muchas gracias. En obvios de tiempo, sabemos que usted tiene otro compromiso ahorita a las 8 de la noche. Quiero finalmente agradecer su participación. Sabemos de su amplia experiencia en esta área. Y pues queremos evitar robarle más tiempo y conflictuarle sus otros compromisos. Le agradecemos a nombre de la doctora Mara Medeiros, presidenta de la Sociedad Mexicana de Trasplantes, que aquí se encuentra. Por ahí le voy a pedir unas palabras. Mara, ¿quieres?
Ay, muchas gracias, Luis Eduardo. Le agradezco muchísimo a la doctora CARRIE esta excelente plática y me agarran con el escándalo del aeropuerto detrás, pero excelente charla y muy pertinente porque nosotros tenemos muchos pacientes que realmente están sensibilizados. El problema es el acceso a plasmaféresis y a rituxia eculísuma, ¿no? Entonces, la posibilidad de trasplante pareado yo creo que es muy buena. La debemos de tener siempre en mente. Muchísimas gracias.
Thank you.
Gracias, doctora Kerry, y have a nice night.
Oh, you too. Thanks for the invitation.